Hi, so I'm Moachri, and I'll be moderating the session, which is the oral abstract presentations looking at adolescence and HIV. So we're in for quite an interesting session with several different presentations that go through the ambit of adolescent care, from transition to the issues around deficits within children or adolescents with HIV. So for the first presenter is Brian Zanoni, who will be speaking on the development and validation of HIV adolescent readiness for transition scale, HART-S. So Brian?
I'd like to thank the organizers for allowing me to present the development and validation of the HIV Adolescent Readiness for Transition Scale, or HARTS, on the behalf of my co-investigators. Approximately 320,000 perinatally HIV-infected children and adolescents are living in South Africa. Yet there are no guidelines on how or when to transition adolescents from pediatric to adult-based care in South Africa. In addition, adolescents living with HIV have poor retention in care and viral suppression after transitioning to adult care. We designed and validated the HIV Adolescent Readiness to Transition Scale, or HARTS, to determine when an adolescent is ready to transition to adult care. For our experimental methods, the HARTS development took place at Mahatma Gandhi Memorial Hospital in South Africa. We included perinatally HIV-infected adolescents who were fully aware of their HIV status and receiving antiretroviral therapy. We initially used focus groups to create the HARTS questionnaire and included 20 adolescents ages 15 to 24 and 11 healthcare providers. We then tested the psychometric properties among 131 adolescents who were receiving antiretroviral therapy. We used generalized linear equation models with the overall HARTS score and with the individual domains. We then correlated the responses to self-described transition readiness and age using linear regression, and then we finally calculated a Cronbach's alpha. The scale was then validated at a separate hospital in a separate township in South Africa. We included adolescents with similar inclusion criteria previously. However, all were attending the pediatric clinic prior to transition to adult clinic. We included 199 adolescents who completed the HARTS questionnaire prior to their transition to adult care. We then measured viral suppression to less than 200 copies per milliliter, 12 months after transitioning to adult care. We used multivariable logistic regression based on the continuous HARTS value and covariates with a p-value of less than 0.2 on bivariate analysis. We adjusted for age at antiretroviral therapy initiation, ART regimen, sex, disclosure status, drug and alcohol use, peer support, and self-esteem. For our results, the participants in both the development and validation cohorts were quite similar. Their median age was between 13 and 14, and most of them were on first-line antiretroviral therapy. For the overall development of the HARTS questionnaire, we determined 4 domains: disclosure, health navigation, self-advocacy, and health literacy. Each question represented 1 to 16 here, represented an individual question on the questionnaire. Each question significantly correlated with the individual domain and the overall HARTS score as indicated by the black box. However, question number 5 did not correlate with its overall domain nor the overall HARTS score and was therefore dropped from the overall HARTS questionnaire. Self-described transition readiness significantly correlated with the overall HARTS score and 3 of the 4 domains, including health navigation, self-advocacy, and health literacy. The Cronbach's alpha for the final score was 0.78. There was no difference in the median test-retest scores among 10% of participants. For the validation, we found that the questionnaire worked best among those with low risk factors for transition, particularly among those who were not using illegal substances at the time of transition and were still on first-line antiretroviral therapy at the time of transition. For those individuals, every 10-point increase in the heart score had an adjusted odds ratio of 0.44 of predicting viral failure. Age at the time of transition was not significantly associated with viral suppression 12 months after transition to adult care. The overall heart score ranged from 0 to 60. We dichotomized the overall heart score to less than or greater than 44. A score greater than 44 represented the top 15% of participants and significantly was associated with viral suppression with a p of 0.01. A score of greater than 44 had a specificity of 90.2% in predicting virologic suppression at the time of transition. It had a lower sensitivity of 21.4, a positive predictive value of 62.1, and a negative predictive value of 60.5. In conclusion, the HEARTS questionnaire is a validated scale to determine adolescent transition readiness. The HEARTS is particularly useful for adolescents without clear concern about transition process, particularly those on first-line antiretroviral therapy and those who are not using illicit drugs. It is useful to predict those who may and who may not need additional services prior to transition from pediatric to adult care.
Thank you, Brian, for that great presentation. The next presenter will be Lindsay Reef, and she will be presenting on the point-of-care viral load testing among adolescents and young adults living with HIV in Haiti, a randomized controlled trial.
Hello, my name is Lindsay Reef, and on behalf of our team from JESCU, Cornell, and Columbia, I'll be presenting the results of our randomized control trial to evaluate point-of-care viral load testing among adolescents and young adults living with HIV in Haiti. This study was conducted at JESCU, which is the French acronym for the Haitian Group for the Study of Kaposi's Sarcoma and Opportunistic Infections. JESCU is the largest HIV clinic in the Caribbean. The HIV prevalence in Haiti ranges from less than 1% to just under 2% for adolescents and youth, with outcomes in this age group across the HIV care cascade worse than both children and adults. Our study objective was to evaluate an intervention to optimize one essential HIV service, viral load testing. An HIV RNA viral load is the biomarker which most effectively measures the continued effect of ART. It enables clinicians to assess the HIV treatment efficacy, and if a viral load is high, can trigger enhanced adherence counseling to improve adherence or a decision to change an ART regimen for those that may be on ineffective or failing treatments. It's an opportunity to assess ART adherence and can be a tool to act, to address barriers or reassess treatment options. Standard viral load testing requires high laboratory capacity using high throughput machines like the Abbott system. Clinics without this capacity must transport samples to a centralized laboratory and link results back to clinics, which can result in delayed or misplaced results. The Cepheid GeneXpert system can process a point-of-care test on site, operated by minimally trained laboratory staff, and can return results the same day. Our hypothesis was that the expert test can reduce logistical complexity, strengthen adherence counseling with same-day results, and lead to improved outcomes. Our study outcomes evaluate both the implementation and effect of point-of-care viral load testing compared to standard laboratory testing. Our primary outcome was the proportion of the test results returned to participants within 6 weeks of sample collection. The secondary outcome was the effect of point-of-care viral load testing on two outcomes, ART adherence and viral load 6 months from testing. Our eligibility criteria included all adolescents and young adults between the ages of 10 and 24 in care at JESCU who had been on ART for at least 6 months, also not pregnant or co-infected with TB or other comorbidities at enrollment. We measured ART adherence two ways. The first by self-report using a 3-item scale adapted from the AIDS Clinical Trials Group questionnaire. The items included 3 questions listed here. The first, on how many days in the last 7 did you miss an ART dose? Second, in the last 7 days, how good of a job did you do taking your ART? And lastly, in the last 7 days, how often did you take your ART in the way your doctor told you? We categorized responses into optimal versus suboptimal adherence and also developed an aggregate scale recoding each response with equal weighting to create a continuous score ranging from 0 to 100, with 100 representing the best possible adherence. Since self-report is known to be subject to bias, as an additional adherence measurement to provide a biomarker to compare with self-reported responses, we measured tenofovir diphosphate levels in the blood. PDF measurements have a half-life of approximately 17 days, which assesses cumulative ART adherence over the past several weeks and months to give an accurate drug level result. We measured TDF drug levels in the first 62 participants enrolled, 31 in each arm who were on TDF. The result is reported as F moles per punch, which can be interpreted as the number of doses per week. Finally, viral load at month 6 was assessed as above or below 1,000. We also assessed change in viral load status between months 1 and 6. This is our full study schema. We enrolled 75 participants in each arm, the standard arm abbreviated as SOC and the point of care arm as POC. Both arms received a viral load test at month 1. The standard arm test results processed in the Abbott were returned to the participant with adherence counseling 1 month after testing at the next clinical visit. Point of care arm viral load test results processed in the Gene Expert were returned with adherence counseling the same day. Viral load tests were administered again for both arms at month 6 when ART adherence and viral load outcomes were assessed. Now to our results. This is a snapshot of the participant baseline characteristics. Median age was similar in both arms. A majority of participants acquired HIV through perinatal transmission, and at enrollment, just over half of participants in both arms had a viral load below 1,000. Overall, there were no significant differences in any clinical or demographic characteristics between the two arms at enrollment. Our primary outcome results describe the implementation steps of viral load testing by arm. For the month 1 test, in red are our primary outcome results. A significantly greater proportion of participants in the point of care arm, 99%, received their test result compared to the standard arm, with 89% of participants receiving their result. These are self-reported ART adherence outcomes at month 6 using the continuous score. Now, in each question, the standard arm reported significantly better adherence, about 10 points higher than the intervention arm. So at first glance, we worried, is a point of care test somehow encouraging worse adherence, which is not what we had expected. So we looked at actual drug level results, the amount of TDF in the blood. We found drug levels were almost identical between arms, so actual adherence was not different despite a difference in self-report. So what wasn't adding up was how accurate self-report was between the randomized arms. To explore this further, we looked at the association between self-reported adherence and the viral load result at month 6. We found that reporting suboptimal adherence was strongly associated with a high viral load in the point of care arm, but this association was much weaker in the standard arm. This graph shows within each arm the odds of having a high viral load above 1,000 when reporting suboptimal adherence. Pink data points are the point of care arm and blue are the standard arm. In the point of care arm, the correlation of poor reported adherence and high viral load was very strong on each question, but in the standard arm, that correlation was much weaker, and in fact, for questions 2 and 3 and the composite, suboptimal ART adherence was not significantly associated with viral load. This told us that the point of care arm was reporting more accurately and honestly that they were not optimally adherent to their ART. Lastly, our viral load outcome results did not show a difference between the two arms at month 6. Just below 60% in each arm had a viral load lower than 1,000, and further, a majority of participants saw no change in their viral load. 44% in both arms were below 1,000 at month 1 and sustained this status at month 6, and about a quarter were above 1,000 and remained above 1,000. Our major conclusions from this study are that first, point of care testing was effectively integrated into a low-resource clinical setting. The clinic and the on-site laboratory successfully adopted a new protocol with a majority of participants receiving same-day results. We also saw the added benefit of more accurate self-report in the point of care arm, which could enable clinicians to both more quickly and accurately identify participants with a high viral load and determine the appropriate course of clinical action to provide enhanced adherence counseling or to change an ART regimen. This evidence together could support more frequent use of point-of-care viral load tests, particularly for patients at high risk for high viral load or at high risk for being lost before the next visit and never receiving the results at all. Thank you very much. I'd like to acknowledge our study team and all collaborators and look forward to taking any questions during the Q&A session. Thank you.
Okay, thank you, Lindsay. So the next presentation is Maureen Sawyer. We'll be going through antiretroviral drug transition and adverse event monitoring among adolescents 15 to 19 years of age in Kenya.
Good morning, good afternoon, and good evening. I am Maureen Sawyer from ICAP at Columbia University, and on behalf of my co-authors, I will discuss the findings of antiretroviral drug transition and adverse event monitoring among adolescents 15 to 19 years of age in Kenya. This is the outline of my presentation. The authors have nothing to disclose. Antiretroviral treatment optimization is critical for sustained viral suppression among children and adolescents. ART optimization began in 2017 in Kenya with the introduction of the dolutegravir-based first-line regimen for adults and adolescents above 15 years of age living with HIV. We described the ART transition, retention, viral suppression, and adverse events among adolescents living with HIV, 15 to 19 years of age in Kenya. We conducted a retrospective observational study using the identified patient-level data from the Kenya National Data Warehouse from 1st July 2019 to 30th June 2020 from 918 health facilities. The figure on the bottom left shows the schema for the enhanced data system, and starting from the extreme left, we began by developing the adverse event symptom checklist using commonly known adverse events associated with antiretroviral drugs currently in use in Kenya and integrated this into the national EMR. Subsequently, we triangulated the patient-level electronic data at facility level between the clinical EMR, the pharmacy ART dispensing tool, and the viral load database, using an interoperability layer to improve the quality of clinical interaction. This patient-level data is subsequently de-identified at facility level and transmitted to the National Data Warehouse for visualization. We used this de-identified database in our analysis. Descriptive statistics were used to summarize patient demographics, regimen distribution, retention, viral suppression, and adverse events among adolescents 15 to 19 years of age. And chi-square tests were calculated to determine the level of significance of viral suppression between dolutegravir and the efavirenz-based regimen. A total of 22,237 adolescents aged 15 to 19 years were identified, accounting for approximately 20% of all estimated adolescents living with HIV 10 to 19 years of age in Kenya. 54% of adolescents living with HIV were female. The mean age was 17 years for both males and females, and 80% of adolescents living with HIV were on first-line antiretroviral treatment. On the left side of the screen, we analyzed the first-line regimen contribution for the 17,865 adolescents on first-line regimen, and 47% were on a DTG-based regimen. On the upper right side of the screen, we present viral load data from adolescents who had a viral load done within the past 12 months. And for the overall population of adolescents, 84% were virally suppressed, whereas those on first-line ART had a viral suppression of 86%. On the lower right graph, we compared viral suppression between dolutegravir and the efavirenz-based regimen, and the viral suppression was at 90% for dolutegravir-based ART and 83% for efavirenz-based ART with a significant p-value. Adverse events were graded for all adolescents on ART using a standardized adverse event grading criteria, and the graded adverse events were recorded as mild, moderate, or severe. There were 2,152 adverse events reported over the data analysis period, representing 10% of all adolescents. Only 6% of adverse events were graded, with majority of the adverse events being ungraded. The bar graph on the right highlights the top 10 adverse events reported, and the top 5 overall adverse events were anemia, headache, abdominal discomfort or pain, hyperlipidemia, and suicide ideation. On the left-hand side of the slide, we see the top 5 ungraded adverse events, and these account for 64% of all adverse events. The adverse events associated with dolutegravir and efavirenz were 48, and these accounted for 2% of all reported adverse events and 45% of antiretroviral-associated adverse events. There were no severe adverse events associated with dolutegravir, while 13 severe adverse events were due to efavirenz, and all these were gynecomastia. On the left side of the screen, we see that the 6-month retention for all adolescents living with HIV with an adverse event and with at least 6 months of follow-up time was at 93%. And on the right side of the screen, we see that the viral suppression for adolescents with an adverse event and who had a viral load result done within the past 12 months was 81% for all adolescents, 98% for adolescents with an ART-related adverse event, and 100% for both dolutegravir and efavirenz-associated adverse events. In conclusion, we see that 1 in 10 adolescents living with HIV aged between 15 to 19 years on ART had a reported adverse event. Adolescents on dolutegravir-based regimen had higher rates of viral suppression, and no dolutegravir-associated severe adverse events were reported. Good retention at 93% and viral suppression at 81% amongst adolescents living with HIV with a documented adverse event. However, there is a need to improve the capacity of the healthcare providers to grade and report on severity of adverse events. I would like to acknowledge the Ministry of Health, NASCOP, the County Health Management Team, the Palladium Group, CHAI, PEPFAR Implementing Partners, the RISE Team, USAID, and PEPFAR. Thank you.
So thank you, Maureen. And the fourth presentation is from Sibon Gilesami, and she will be speaking on bringing HIV and sexual reproductive health services closer in adolescent girls and young women in Eswatini through a comprehensive mobile HIV and sexual reproductive health package.
Afternoon, everyone. My name is Sibon Gilesami. I'm going to be taking you through a topic that says bringing HIV and sexual reproductive health services closer to adolescent girls and young women in Eswatini through a comprehensive mobile HIV and SRH package. Adolescent girls and young women, they continue to lag behind in the 95 targets, and they are the hardest hit by the HIV epidemic. Their vulnerability is caused by issues like gender-based violence, lack of access to health services, and education. In April 2018, there was a project called Insika Yakusasa or RRR that was initiated, and this goal was to prevent new HIV infections and reduce vulnerability among adolescent girls and young women in Eswatini. The project is implemented in 24 rural and urban communities, whereby we provide mobile clinical outreach services to deliver HIV and sexual reproductive health services. The mobile clinical outreaches, they are known as Dreams on Wheel, and they are used to reach adolescent girls within their communities where we can find them, like community centers, churches, or near schools. Each mobile clinical outreach unit has got a nurse, an HIV testing service counselor, a peer educator, and a driver. The mobile unit, they visit each community at least once a month, and they provide the services during convenient hours, including weekends. The adolescent girls, they are referred to the Dreams on Wheel by community cadres that are employed by the project. The community cadres, they are the ones that create demand for mobile services. They do this through mentorship when they are doing social asset building, or through small group which they conduct for prevention sessions. Also, the services are advertised through Facebook and also WhatsApp. They also make the girls aware of their risk through job aids such as HIV risk screening, PrEP, SRH job aids that they use during these meetings. The community cadres also identify the needs of adolescent girls at household level, and they refer them to the Dreams on Wheel. The services that are available at Dreams on Wheel include HIV testing and counseling, family planning, screening for STIs, HIV treatment, and the documents that are used for recording the services were specifically designed for this project. The results of this project are as follows. Between 2018 October to March 2020, 1,191 mobile clinical outreach services were carried out in the 24 communities, where we managed to see 19,643 adolescent girls aged between 10 to 24. The majority of the clients that were seen in the mobile clinical outreaches were the 15 to 19, where we saw 9,255. Most of the clients were coming from the rural areas, and most of the clients were referred by the community cadres. In terms of service uptake, of the 19,643 adolescent girls and young women that came through the mobile units, 10,000 of them were eligible for HIV testing, and 98.9% received HIV testing. And we identified 146 HIV positive adolescent girls and young women, and 137 of them were initiated on ART, which is 94%. 95% of the clients were screened for STIs, and we identified 59 to have STIs. In terms of family planning, counseling, and services, 72.9 clients received that, and 1,999 also received the family planning commodities other than condoms. 274 clients were also tested for pregnancy, and we identified 54 adolescent girls and young women to be pregnant. In terms of HIV testing uptake, the uptake among the 10 to 14 was also high. 1,336 clients tested for HIV among the 1,379 that were eligible. Also among the 15 to 19 and 20 to 24, the uptake was also high, above 95%. In terms of positivity and ART initiation, there was a high uptake of ART initiation among the 10 to 14, as all of the HIV positive clients that were identified were initiated. There were challenges within the 15 to 19, where we missed 3 clients, and there were 6 clients that were missed among the 20 to 24. As the clients highlighted that they are not ready for ART initiation, they still need to consult with their partners. In terms of STI screening, 59 clients tested positive for STI, and 27 of those managed to access a treatment. Condom uptake was also high in terms of the type of condom that were the adolescent girls and young women received. Both female and male condoms were taken almost at the same rate. In terms of family planning commodities, the injectables were the most favored, followed by the oral contraceptives, and also with clients taking up implants. When we look at pregnancy, the majority of clients that we tested for pregnancy that tested positive were among the 20 to 24, followed by the teenagers, 15 to 19. We didn't have any 10 to 14 that were reported to be pregnant. In conclusion, it is feasible to provide integrated services which are friendly and comprehensive to adolescent girls in the community, where they can access it at the time that is convenient to them. Also, strong linkages between the community and the clinical platform ensured that adolescent girls are able to seek HIV and SRH services. Mentorship and targeted HIV education also increased awareness about the risk that the adolescent girls are facing, and also they were able to identify them and promote them to access services. Pregnancy remains an issue, and there is need to tailor pregnancy prevention support to be specific to this age group. The project should continue and also scale up services like PrEP and ensure that STI services are available to the adolescent girls and young women in the community. Thank you.
So thank you, Sibon Gilesami. And the next presenter is Joseph Fukama, who will go through archived HIV-1 drug-resistant variants in cellular reservoirs and its determinants among vertically infected adolescents failing antiretroviral treatment.
The study we are about to present is entitled Archived HIV-1 Drug Resistance Variants in Cellular Reservoirs and its Determinants Among Vertically Infected Adolescents Failing Antiretroviral Therapy in Cameroon. Briefly, there is an overall decreasing mortality of HIV in all age range, except for the age of adolescents, where we are seeing an increasing rate of mortality. In the Cameroonian context, where we have 3% HIV prevalence, we still have more than 10% mother-to-child transmission, indicating that these children born with HIV going towards adolescence might experience therapeutic challenges as well. Viral suppression among adults is 80% as compared to 55% in adolescents, and adolescents failing antiretroviral therapy have higher risks of harboring HIV drug resistance mutation. In this context, we raise the following hypothesis. Drug resistance mutation may fade up as children with perinatal infection grow up, and those harboring archived drug resistance in cellular reservoir might have a high rate of treatment compromisation in future. As study objective, we seek to compare the mutational profile of HIV drug resistance mutation between circulating RNA and proviral DNA among those failing treatment, and to study the determinants of archived drug resistance mutation in these adolescents. To address this objective, we carried out a comparative assessment among 296 adolescents ethically infected receiving antiretroviral therapy in 5 treatment sites in Cameroon, and we did clinical assessment and self-reported adherence. CD4 and viral load were measured for all participants, and we compared the RNA and coviral DNA genotyping for those having high viral load. In a nutshell, out of 296 that were enrolled, we had at the end 48 with both RNA and DNA sequences that were eligible for the study. These were adolescents with a median age of 16, similar sex ratio, 5 log in terms of viremia, and half of them were at advanced disease progression. Treatment duration was 8 years, with majority of them being on NRTI-based regimen. Sequences comparison between RNA and DNA showed 100% concordance, thereby indicating reliability in the quality of sequences. CRF0280 was the most prevalent, and we also have 2 potential recombinants. Drug resistance mutations were higher in RNA as compared to proviral DNA, especially for NRTI and NRTI mutations. And in terms of drug mutations by class, we had M184V more prevalent for NRTI, with T69N being more prevalent in proviral DNA. For NRTI, we had K103N being more prevalent in plasma, whereas V106 and M230 were more prevalent in proviral DNA. As you mentioned, PI were similar in both compartments. Finally, the presence of drug resistance higher in plasma as compared to proviral DNA showed a significant disparity. Concordance mutation between RNA and proviral DNA was in less than 40% of participants, driven by a WHO stage 1 and 2, and archived drug resistant mutation found only in proviral DNA were seen in about 25% of adolescents. And archive of this drug resistant mutation were driven by an advanced clinical staging and also very poor CD4 count. Thereby, OCO drug resistant mutation is driven by advanced clinical staging and CD4 naive. In conclusion, about 1/3 of adolescents are experiencing antiretroviral therapy failure. Plasma represents a more sensitive biological specimen for drug resistance analysis in clinical settings. However, archived drug resistant mutations are found in about 1/4 of these adolescents, driven by advanced clinical stages and severe immunodeficiency. In future, we will seek, therefore, to compare the resistance profile between those with high and poor viral load, as well as characterizing the viral reservoir size, comparing immune activation, and performing HIV functional cure studies in this population. We would like to thank ECTP and the various partners who supported this work at the level of Cameroon. Thank you for your kind attention.
So thank you, Joseph. And the final presentation is from Barbara Lawton from South Africa, who will be giving us a presentation on deficits noted at 11 years in children with HIV starting early antiretroviral treatment in fine motor dexterity and auditory working memory.
Greetings from Cape Town, South Africa. We are grateful for the opportunity to present results from the SURE cohort at 11 years of age. The SURE trial, conducted at 2 sites in South Africa, compared early time-limited antiretroviral therapy in young asymptomatic infants who were perinatally infected with HIV. Infants were enrolled before 12 weeks of age, and those with CD4 percentages 25% or higher were randomized into 3 treatment strategies. The trial confirmed superiority of early time-limited ART over deferred continuous ART. Participants at the Cape Town site were co-enrolled on a longitudinal neurocognitive and neuroimaging study along with children who did not have HIV. We also included a subgroup of participants perinatally infected with HIV with CD4 counts less than 25%. This is a cross-sectional descriptive study of a longitudinal cohort. The SURE treatment arms of children perinatally infected with HIV were combined into one group. Children HIV exposed and uninfected, and children HIV unexposed were enrolled from similar neighborhoods as controls. We conducted a comprehensive neurocognitive battery at 11 years of age. ANOVAs were used to compare the neurocognitive scores of the groups, and means were adjusted for significant variables. Characteristics of 3 groups are presented in this table. There was a significant difference in gender, with less girls in this exposed uninfected group. The HIV group had a lower proportion of children with mothers as caregivers. We had an in-house caregiver stress measure, including exposure to violence and coping skills, and the feeling of having enough support, which did not show any difference between the groups. There was no difference in school grade distribution. The HIV-infected children were shorter than their counterparts. There was a significantly lower proportion of children whose test language was isiXhosa in the unexposed group. The children with HIV had started ART at a median of 9 weeks of age. 35% had ART interrupted at 40 weeks on study, and 19% were interrupted at 96 weeks on study. The median time that ART was interrupted in these participants was almost 35 weeks. Note that 77% were still on their original ART regimen started as infants, zidovudine, lamivudine, lopinavir, and ritonavir. At 11 years, the HIV group had a median CD4 percentage of 38.4 and an absolute count of 959. 21% had detectable HIV virus within 6 months of their neurocognitive assessments. These levels were low, with a median of 156 copies per mil, and the range was 22 to 1,841. 20% of the participants had previous diagnosis of HIV encephalopathy. On the neurocognitive battery, there was no difference between groups on visual motor integration tests, the Berry VMI or the Ray complex figure tests, or on the semantic fluency test. However, on the Purdue pegboard test, both hands, the children unexposed to HIV performed significantly better than those with HIV exposure. There was no difference between groups on the various domains of the Kaufman assessment battery for children after adjusting for important variables. Notice how the p-value for sequential processing, which is a measure of working memory, changed once we had adjusted for gender, test language, and mother as caregiver. The word order subtest contributes to working memory. And in this subtest, names of objects are first read to the child, who is then required to point to the pictures in the correct order once they are uncovered. Note the English words are all monosyllabic, and the isiXhosa words are much longer, making it harder for those children to remember the words. This can be a problem when comparing groups with different test language proportions, and also when describing results using standardized norms. I wanted to take time to share this example with you, as it forced us to change our title of our abstract and our findings. This early treatment cohort is actually doing very well, in contrast to other findings where children have global deficits, but most of them had not started antiretroviral therapy this early. Despite their early ART and careful clinical management, there are still persistent mild deficits in fine motor, speed, and dexterity tests, which was also described in a poster at 7 and 9 years of age at the cohort at this meeting. It is essential to adjust for important covariates. We plan to continue our exploration of these outcomes, including assessments for predictors and correlates of outcomes, including the neuroimaging and neural pathways that affect and control fine motor, speed, and dexterity tests. This study would not have been possible without many important role players and funders, and we would like to thank them all and acknowledge them.